The syndrome is delirium can be defined as acute brain failure associated with automatic dysfunction, motor dysfunction, and homeostatic failure. It is a complex and often multifactorial and hence continues to be underdiagnosed and poorly managed. Even then, detected early and managed, delirium can lead to significant mortality and morbidity in frail elderly patients. Adverse outcomes can include the following: prolonged hospital stay, increased mortality whilst in hospital in the months following discharge, increased risk of developing complications such as hospital current infection, pressure ulcer, and falls, poor physical and cognitive recovery at 6 and 11 months, increased risk of placement in the residential home. ADAPT tool for geriatric patients with a delirium. Previous data have highlighted the under-recording and under-treatment of delirium in geriatric patients. They created this tool, and a cohort of Fijian geriatric experts performed a literature review and identified 5 points interested in the realm and geriatric delirium, creating the ADAPT tool. It's access, diagnose, evaluate, prevent, and treat in an attempt to remind physicians about the high risk of untreated delirium and offer guidance of management for both the symptoms and the underlying causes. Predisposing factors, it's microvascular changes, altered body composition, oxidative stress, neuroendocrine dysfunctions, and neuroanatomical abnormalities. Acute stresses, delirium impacted neurovascular coping, hypoxia, hypoglycemia, and physical and physiological stress, and neurosystemic alternatives and medications, which includes for detecting health. It's a full health-related outcomes, disability, hospitalization, and the last one is the death. Frail score for geriatric patients, appropriate assessment of patients' frailty may help predict the length of stay if admitted to the hospital and determine which patients are most likely to require placement in a skilled nursing facility and the time of discharge. Comprehensive geriatric assessment is defined as a multidimensional interdisciplinary diagnosis process for determining the medical, physiological, and functional capabilities of an older person in order to develop a coordinated and integrated plan for treatment and long-term follow-up. Comprehensive geriatric assessment improves outcomes for older people in various settings, including reduced mortality of deterioration, improved cognition, improved quality of life, reduced length of stay, reduced rates of long-term care use, and reduced costs. The principles of comprehensive geriatric assessment include identified problems across health and social care domains, establish priorities, individuals management, interference, and follow-up and review. And for conclusion, innovate, practice, and technologies offer encouraging promise for the provision of essential health care services for older people worldwide. However, the extent of this service appears to be currently limited in low and low middle income countries, and many of them have lack of evidence basis. Studying and optimizing the services that can be accessed by older people requires greater government investment and active engagement by broader participation of older people, the caregivers, physicians, and other health care providers. technologies experts, and health managers. Thank you for attention.
This is the third speaker is Dr. Hikmet Anvarov, Deputy Director of Center of Emergency Medicine, Tashkent, Uzbekistan. Yes, please.
Herkese merhaba. Dear Chairman, it's a great honor for me to stay here before you. So, the literature update, it's quite a tough issue to bring here within short 10 or 15 minutes, and we try to do our best just to overview it the last maybe 2 or 3 years. And if the some publishing wouldn't be sound here, it doesn't matter. It doesn't mean that it's not significant. It means that we are lazy to find it. So this is my disclaimer. While preparing this presentation, I found that 2 significant publishing in the American Journal of Emergency Medicine. So the 2 authors, Dania Huja and Nicole Simina-Fialos, they especially reviewed this topic in 2019 and 2020, the geriatric emergency literature in 2019 and geriatric emergency literature 2020, COVID and beyond. Of course, the new topic, the COVID-19, makes its own changes in this topic. So below are selected articles from these 2 years that changing our practice and highlighting the trajectory of the future endeavors in geriatric emergency care. So just to highlight the main streams, main trends in these 2 years for geriatric, I would say the COVID-19 caused worse outcomes in older adults, of course. The modified Pro-Age score can provide an estimated outcome prognosis. As it has been sounded here, delirium is a common presentation of COVID-19 in elderly and maybe primary presentation. Family presence is an integral part of reducing delirium in the ER and should be encouraged. Radiological occult hip fractures are common and may be missed in the hip CT. And certain injury patterns are specific to elderly abuse, such as maxillofacial, dental, or knee injuries, especially in the absence of lower extremity injuries. And conclusion that acute coronary syndrome is rare in elderly adults with non-specific complaints, and that the patients with elevated troponin do not have acute coronary syndromes. Parenteral using of non-steroidal anti-inflammatory drugs may be safe to use in relatively healthy elderly adults with low prevalence of comorbidities. Frail patients are at the higher risk of bad outcomes and may benefit from early identification and tailored discharge planning. Arranging primary care or specialist follow-up for older people within 10-12 days of ED discharge decrease ED recidivism. And addressing the physical needs of elderly people, decreasing wait times and improving the communication may improve the elderly patient's ED experience. And of course, data is currently insufficient. So talking about the COVID-19, the previous speakers, I think they highlighted very well them. So I founded this article by Alberti, Kovinsky, and others, a fuller picture of COVID-19 prognosis, the added value of vulnerability measures to predict mortality in hospitalized elder adults. In Journal of Aging, the study also provides the clinicians in ED with a framework to prepare patients and their families for the possible outcomes of hospitalization for COVID-19. Offering patients and their families a reliable approach to prognostication and the onset of illness may help facilitate end-of-life conversation, plan for likely need of skilled nursing facility, placement after the hospital discharge, and outline realistic expectation for the outcome of their hospitalization. Also, delirium, again, it's stressed that delirium is frequent presentation of COVID-19 in elderly adults in the ED. It can be start as a first manifestation either as a primary symptom or part of the atypical COVID-19 presentation. These data highlights the importance of delirium screening now than ever, reiterating the geriatric emergency department guidelines recommendation. This increased frequency of delirium in elder adults with COVID-19, which is higher than will be expected in the general geriatric ED population, in line with regular neuropsychiatric manifestation in the general COVID-19 adult population. So this is quite interesting article by Deng and Chow and others non-pharmacological interventions to reduce the incidence and duration of delirium in critical ill patients. Systematic review and network and meta-analysis founded in Journal of Critical Care. So this study provides additional support to emphasize the family-centered care that is integral to geriatric ED. The needs of advocate for family presence is now more than important than ever. Excluding caregivers of patients at high risk for delirium from visitor restriction policies has been in the focus of many geriatric experts and a priority for patient-centered care. Hip fractures. So the Haj Mirzayan and others in the Journal of Radiology highlights the advanced imaging should be strongly considered in patients with apparent isolated greater trochanter fractures, given the high rate of fracture extension into the intertrochanteric region and coexistence of a surgical fracture. Non-specific presentations, also the group of authors, Wang and others, in the article Testing and Coronary Syndrome in Geriatric Patients with Non-Specific Complaints, our testing in academic emergency medicine, highlights that understanding of the truth of harm of obtaining of troponin level in elderly adults with non-specific presentations and subsequently chasing the result will require discerning whether the sole purpose of the admission was to investigate the troponin elevation, even patients would have admitted anyway for another cause. Is admission to the hospital in elder adults is associated with a functional decline and mortality. Despite these limitations, this study should make us reconsider ordering troponin in elder adults with non-specific presentation and seriously consider non-ACS causes for troponin elevation in them. Pain management also highlighted in the article by Anderson and others in the American Journal of Emergency Medicine in June 2019. And simply stated, parenteral ketorolac may be safe to these kind of patients in relatively healthy elder adults with low prevalence of the comorbidities, specifically those who are well enough to be discharged. Frailty, and again frailty for adults, I think this is one of the main issues. So Lewis and others in the article named which frailty scale for patient admitted via emergency department cohort study in archives of gerontology geriatry in 2019 highlights that importance of frailty screening, but also appreciate the difficulty in dedicating time to screening in a busy emergency department. And they're offering the clinical frailty scale, which is presented on the slide. And I think most close for us is geriatric emergency department, highlighted in the article by Megidson and others, prompt outpatient care for elder adults discharged from the emergency department, reduce recidivism from Western Journal of Emergency Medicine, October 2020. So demonstrate that more than 20%, 1/5 of elder adults discharged from ED will have a repeat visit to the ED within 1 month. Elder patients, those with more comorbidities and those with a lower socioeconomic status, were the most likely to return back to the ED for a repeat visit within 3 months. If patients were able to see a primary care practitioner or specialist within 1 month following their ED visit, they had a decreased ED recidivism rate more so if within 10-12 days of discharge. So delayed follow-up visits did not affect the recidivism rate, and authors speculate the further improvement of the transitional care after ED discharge may be accomplished by standardizing the communication between ED and outpatient practitioners. Elderly abuse is highlighted in the article by Rosen and others, identifying injury patterns associated with a physician elder abuse, analysis of legally adjudicated cases in Annals of Emergency Medicine. So investigators determined that physical abuse victims were more likely to have bruising and injuries of the maxillofacial, dental, or neck region, especially in the left cheek, left face, and ears for righties. Neck injuries specifically should trigger physicians to think of abuse as a mechanism for injury, especially as the neck is typically protected during a fall. Victims of maltreatment were less likely to have any fractures or lower extremity. Also, I would like just to share with you some fragments of this document, which is not a brand new. It's dated by 2014, but nevertheless, this is a geriatric emergency department guidelines. I think most of you are quite familiar with that. So the document is a product of 2 years of consensus-based work that includes representatives from a lot of very distinguished societies. And they provide this, I would say, universal scheme of the algorithm of the elderly patient in ED. Also, this document, Disaster Preparedness for Seniors, a comprehensive guide for healthcare professionals made by Springer Publishers, outlines specific disaster scenarios for homebound, community, hospitalized, long-term care, homeless, and aged veteran. Just browsing some European journals, we found that they mostly focused on the quality issues. So the Schuster and others in Scandinavian Journal of Trauma, Resuscitation, and Emergency Medicine, in 2020, they highlighted in the article quality indicators for the geriatric emergency care and evidence-based Delphi consensus approach to improve the care of geriatric patients in the emergency department. This quite, I would say, unique and original algorithm how to provide the quality issues in elderly people. And they provide their questionnaire, which they consider as a gold standard to measure, benchmark, and improve emergency care. So they call it GERI-QED. Questionnaire should be focused on a clinical experience and research-based recommendation and describe the first time a standard for geriatric emergency care in Germany. So this questionnaire should be implemented by authors as a standard, minimal standard in geriatric emergency care. One more paper dedicated to quality issues in elderly emergency by Mujard and others from the Geriatric Emergency Medicine. They present a top of 10 high priority research questions for European research agenda for geriatric emergency medicine. The list of research questions may serve as a guideline for researchers, policymakers, and funding bodies in prioritizing future research projects. Thank you for your attention.
Thank you very much. If is any question, please. If it's in Turkish, please help me with the translation.
Thank you very much, dear Chair, and thank you very much to Dr. Sirina today, Daylan and Dr. Hikmet for the nice presentation. My aim is just to have an addition about the comment, and I will do some recommendation if you give permission me. What?
It's for Dr. Srinath?
No. I just want to have some addition and recommendation about this issue.
No, any recommendation?
Let me repeat it again. I do not have a question. I just want to have some addition
Yes,
and
please.
recommendation about this issue. Thank you very much. Since 20 years, when I am looking from the windows of the emergency medicine, emergency medicine rooms, and emergency training, I saw that even though the world is dealing with a great disaster, it is COVID since 2 years. This is a war, and everybody is struggling with this war. I think we have another big disaster. What is that? This is the adults. How can we deal with our adults? Because in this century, in the advanced country, at the advancing country, they have facility and they have chance to have their adults for their survival. But when we look at the situation, we see that the development countries, they achieved very good points. What is that? It is that they decrease the mortality of the obstetrics patient and the newborn. This is a good point that should be appreciated by everybody. We do it. But now they face a new problem. It is the adult and their serve. Because when we look at it from the emergency, we see that their cost is very high. Their stay in hospital is very high in intensive care units. And the state emergency department is really very high. And their restriction to the treatment is a big problem. And they have many complications of the treatment also, and they also have very high mortality and morbidity. The emergency department is a problem for us and also for them, because nobody wants to host them. Nobody wants to get this patient to their clinics. So they stay in the emergency department for a long time. So they struggle with the staffs, with the care. So what do we need for this patient? I think we need a new mentality. The authority needs to change their mentality for the adults. They need new construction of hospitals. They need to construct new hospital for the adults. How to care this patient? Suitable places. And also when they take their care in hospital, they need to transfer to new institution. Think they will be immobilized. And also we need a mentality to increase how we care their patient in their home. So one recommend for the drug company is that please work too much to produce new drugs and posology and new doses for this group. And especially I have a recommend for my colleague, young colleague, because Dr. Kumar, me and Dr. Mustafa, we are adults, and the others are youngs. If you want to work on a new area, this is the adults. If we have chance to do it. Thank you very much.
Thank you.
Dr. Behçet, I'll thank you very much for your recommendation, all of us. A few minutes later, in the beginning of the ceremony, I will represent a Turkish first geriatric emergency medicines project. So I agree with you. This is so important issue. All of us, we are going to getting ages. So this is a kind of war, as you mentioned also. Thank you very much for your support. Thank you. Is any question or any comment? It's okay, maybe we can finish. Yeah, we can finish. No question. Yes. Okay, we are closing this issue. Thank you very much for your participation. Thank you.
Morning, and thank you, Eric, for this brief introduction. Thank you to all the attendees to be here in this room in this early session, and thank you for those who are connected online. Today we are really pleased to have two members, two presenters online, The first one is going to be presented by Eric Review. So please, Eric.
So we'll start with the colleagues on Zoom. Zoom first, sorry, because they are online. And so we'll have a colleague from China, Africa, and then our speakers. Sorry, we just don't want to have not technical problems. Okay, so it's a pleasure to introduce from China Dr. Wang Zong. Can you hear us, Dr. Zong? Yes.
Yes, I can hear clearly.
Great.
Yes, can you hear me?
Yes, we can hear you. Please go on.
Okay, good morning, everyone.
Professor Wang Zheng, can you hear me?
Yes, I can. Yes, I can hear you.
You can start, please. We can hear.
Pardon me?
We can hear. You can start if you are ready.
Oh, I'm sorry. I do not have a presentation. Miss Wei Jie will in charge of on behalf of the China to have something to share with you. Okay.
Yes. Okay. Go on, please. You can speak now.
Okay, 魏老师。
Hi. Hi.
Hi, Wei. Welcome to the meeting.
Hi, Wei. Luis?
Yep. We can see you.
Okay, can you hear me? Can you hear me?
We are waiting for your presentation, Wei.
Oh, okay. Okay, I'm in another meeting room. I just want to find some place to speak with you. Just a moment. Maybe here is better. Okay. Okay, maybe here is better to speak with all of you. And according to my President Dr. Wang Zong, I will say something about COVID-19 in China and about Chinese Emergency Medicine Society. How do we do right now? And actually here in China, we don't have what you called maybe the native cases here, only a few, sometimes from here, sometimes from that place. And we have some cases from outside of China. So what we are doing now is just to keep them alert and do some choose. And we have I once spoke with Luis, and we have a special clinic called Fever Clinic. And the fever clinic is just in the front of triage of emergency department would we called the pre-triage system. And this system could protect the emergency department to keep the fever patient outside of emergency department. So in this, we do think we are more safe this time, better than something happened before during the 2019 and 2020. This is the situation right here. And we should do our best to balance the common cases and some.
We have some technical problems with our Chinese colleagues. We will try to solve them.
I'm so sorry. I'm so sorry for the line because the connection is not so good. Can you hear me, please?
Yes, you are online.
Okay, okay. I just find a place. Maybe the situation is better. So this is what we are doing now. Okay.
Thank you, Wei. Anything more to report from your side?
No, I think, I think maybe for me it's okay, and I just want to know if my president has some idea or has some speeches to give. Wang 教授.
Good. Yeah, I'm here. I can hear. Thank you for all of you. Because I am located in Beijing, and Beijing have not more patients here. So we do not do more work about the COVID-19. We just do some prevention and to limit the spread rate of the disease. Why I choose Miss Wei to share the experience with you, because they did a lot of work. But right now, all of China have not a few patients. We just some patients come from abroad. So our work right now is to do my best to prevent the patients and prevent the separate. We do give all of the people injection of the vaccine. Right now we have finished about 16 billion, right, 60 billion injection about all of the China, yeah. So that's I want to share to you. And I'd like to listen to other experts to share, and then we can discuss about the things. Thank you.
Thank you, Dr. Wong. Thank you for your ideas, and thank you, Dr. Wei, for your presentation. We are going to move forward. If you are going to be online, please keep attention to the next presentations. Next speaker. Roger, we are going to try to connect with South Africa and see if Dr. Roger Dixon is online.
Good morning, Lewis. Good morning, Eric, and good morning, everybody in the room and online. I am saying very good morning on a bright and sunny spring day in Cape Town.
Thank you, Roger. We can hear you clear, so whenever you want, your floor is yours.
Well, thank you very much. It is a pleasure to be involved in the EPAD conference once again, and it's also fantastic to hear such familiar voices and see familiar faces on the screen. And it really is an absolute pleasure. It really goes to show that although the globe is huge, it is very small when it comes to sharing information and for being able to draw on each other's experiences and knowledge. And so it doesn't matter if you're sitting in Antalya or on the southern tip of the African continent, we are able to share knowledge and experiences, and that is how we are able to progress our discipline. This is my hometown. My hospital sits in the middle of the waterfront in Cape Town, and we have been one of the designated COVID-19 hospitals for the province and have been actively involved in its management. Although I'm not in Antalya at the moment, I have been watching the activities from afar, and it's really great to see familiar faces having a great time. And please know that I am there in spirit. It gives me great pleasure to be able to present some of the background regarding the COVID-19 epidemic in South Africa, and the approaches taken in ensuring that we are able to provide the best possible care, though it has been challenging at times. For this presentation, I have nothing to declare other than the fact that I'm an emergency physician and I come with the requisite warnings. I think like the rest of the world, we watched the emergence of the, at the time, unknown respiratory pathogen that later became known as SARS-CoV-2. And I think what started to become apparent as it developed in Wuhan and then spread into Europe and the Americas was the high number of fatalities that seemed to be associated with it. And I don't know about you, but that got me really, really worried. Knowing that the health infrastructure on the African continent is often less than ideal, is looking at how we were going to be able to provide care that seemingly first world countries were struggling with. And it came down to caseloads and resource requirements that these cases seem to need. So I told myself, no problem, just keep calm and we'll maybe not that calm, but we would need to watch and see and plan. And as we always do when we're emergency physicians facing a challenge, we just make a plan. So we first heard about the virus emergence in November 2019, but it was only a few months later, and that was in March of 2020, when we saw the first case being documented in South Africa. And all of the original cases were imported from abroad by travelers, and these were both by local nationals who had traveled abroad and had come back, or by foreign tourists who had traveled in from areas. And it seems that whilst it is not that long ago, we are looking at just over 18 months ago, so much has happened between March 2020 and October 2021. This virus has affected every country on the globe and has had significant impact. And looking at the Worldometer stats last night, looking just over 240 million cases with nearly 5 million deaths associated with it. If we look at the international spread of cases, we can see that they have followed in waves, and we've seen a similar pattern here in South Africa. So if I look at the COVID response in South Africa, just to give you an update as to where we stand, we currently have a total just shy of 3 million documented cases, with about 90,000 deaths. These have appeared in three very distinct waves. Initially starting with the first case in March of 2020, the peak of the first wave being in August of last year, the peak of the second wave being in January of this year, and we have just passed the peak of the third wave at the end of July of this year and have just officially exited the third wave. What has been noted, though, is the variant dominance for the various waves. We saw that the first wave was a mixed variant. There was no particular variant that dominated. The second wave was the so-called beta variant, which was initially described in South Africa and has since spread across the globe. And then the third wave was dominated by the so-called Delta variant. And what we have seen with these three waves is that each successive wave has produced higher numbers of patients and has an increased duration of wave. And this has certainly put strain onto the healthcare facilities and in particular, the healthcare workers that are dealing with it. The updated numbers from this morning show that in the past 24 hours, we had 942 new cases diagnosed and documented in the country, bringing our cumulative numbers up to just less than 3 million. We do see a gender preference in that there are more women that have been documented to have COVID-19 than men. And if we look at the age groups from a case numbers perspective, they predominate in the middle age groups, which is understandable in that they tend to be the more out and about individuals engaged in commerce, engaged in schooling, whereas the other age groups tend to have been protected either by social distancing or by early vaccinations. The initial response from our government, and this was back in March of 2020, was to institute the infamous lockdowns. And our country put into place adjusted alert levels, and this was determined by the number of case numbers, and from that, the number of hospital admissions that were anticipated. And it raised from alert level 5, which was complete lockdown. Only essential workers were allowed to leave their homes. And it included things like alcohol and cigarette bans for that period. And that alert level lasted for a period of 6 weeks. We've then seen, as we've moved through the different waves, variations between level 1 and level 4, and these are adjusted according to the current case numbers and the anticipated pressure on hospitals. There has been an attempt to achieve balance, understanding that we cannot be in lockdown forever. You cannot hide from a virus, and whilst we are trying to protect lives, we also need to be able to protect livelihoods. And that really has been the buzz phrase from our state president, was to the objectives being to protect lives and to protect livelihoods. The initial messaging was fairly simplistic and really came down to maintaining good hygiene with appropriate hand care and hand washing, social distancing, and the use of face masks. And this was really the mainstay of the initial response, which initially was met with enthusiasm by the population. But as we've progressed over the last 18 months, we have seen a degree of pandemic fatigue, where people are tired of wearing masks, where people are tired of distancing from their friends and families. And so there's often been some conflict between these basic ideals of prevention of pandemic spread and the ability in order to achieve them. Unfortunately, though, even with these activities and with the initial preparations that the hospitals faced, the facilities and healthcare workers soon became overwhelmed. And we started seeing increased numbers of hospital admissions, pressure on intensive care beds, to the point that it was more likely that you would not get an intensive care bed even if you needed it. And with that, we saw an increase in the number of fatalities. What followed on was, in several major centers, saw the establishment of field hospitals. And the field hospitals were set up in mainly conference centers, the largest one being in the Cape Town International Conference Center, which had 1,400 beds. And the field hospitals were designed to act as step-down facilities from the main hospitals. So patients that required care, required oxygen, but were not requiring any of the intensive modalities, were stepped down to the field hospitals and then discharged from there. And they functioned incredibly well. Whilst not all of them have been maintained for the duration of the pandemic, some are certainly in operation as we speak. What has become clear is that the only way to fight a virus is not to hide from it, but to protect oneself against it. And so we were watching the developments with regards the vaccines internationally, and it became very apparent that that was the route that we needed to go as a country. Seemingly in conflict with the concept of social distancing, there were numerous social protests with regards to our population demanding early access to the vaccine. South Africa is not unique on the African continent, and the selection of the various vaccines needed to be done carefully, not only from a pricing perspective and an access to the vaccine perspective, but also looking at the ability to store it, and also looking at the number of doses that would be required. And this is particularly true considering a lot of the very rural areas that are apparent on the African continent, and especially in South Africa, where access to the vaccine would be a problem, and access to vaccines that required supranormal chilling would pose a logistical nightmare. And so after much discussion amongst the scientific community within South Africa, it was decided to go with two of the available vaccines, the first being the Johnson & Johnson vaccine as a single dose vaccine. It was also more stable at commercially available refrigeration. The second was the Pfizer vaccine, or the 2-dose regimen. And Initially, there was a phased rollout of the vaccines. So initially, it was rolled out to healthcare workers. The initial healthcare worker rollout was still under one of the utilization studies, the so-called Sasonki trial. And so the healthcare workers in the country were vaccinated with the Johnson & Johnson single-dose regime way back as early as February of this year. Initial stocks were difficult to obtain, and as can be seen on this slide, it was really only in June that we started seeing the exponential increase in the number of vaccine doses. Now, the aim is to have 60 to 70% of the adult population fully vaccinated by the end of this year. We are currently sitting at between 40 and 50% of the adult population fully vaccinated at present. And so we still have quite a lot of work to do in that regard. But we have seen a massive increase in the number of vaccines delivered. We do see a provincial variation with regards to the vaccine, and that is we do operate in South Africa on a federalized system within the different provinces. And so there has been variation in the installation of the vaccination programs. Also, there are different populations in various places. And so whilst we do see a Manhattan graph amongst the different provinces, it is not always due to a lack of infrastructure availability, but rather a lack of population in order for that to occur. I mentioned that we have adopted a phased rollout of our vaccinations, and following on from the healthcare workers and the essential workers, we then started with vaccinating those 60 years and above, with in later introducing those for 50 to 59, 35 to 49, and most recently the 18 to 34 age group. And so whilst we do see variations in the proportions of the population that have been vaccinated in these various groups, it should be understood that the time that these individual groups have had to be vaccinated varies. And so the 18 to 34 groups have only been open for vaccination for the past 6 weeks, whereas the 60 plus years have been open for vaccination from June. And so we are making progress in that regard. I'd say one of the biggest challenges we've had with regards to vaccination comes to quite a vehement anti-vaccination lobby that has emerged within South Africa. And there have been numerous protests regarding what are viewed as sometimes draconian approaches from our national government. And these include the forced isolation, the use of face masks, the curfews that have been in place, the bans on certain substances during these curfews, and it has led to a lot of conflict. And we can see these were two protests that occurred, one outside of one of the large hospitals in Cape Town, which really did a lot of damage to the morale of the healthcare workers working within it. And then others have been protesting in very public areas. And you'll notice that the use of face masks is considered against their human rights. The use of vaccine is considered against their human rights. And it has created a lot of conflict. And I think just to finish up, it has led us to where we have our greatest difficulty at present, and that is with regards to our healthcare workers. They have been through 3 waves now, each wave larger and longer than the one before. They have poured in their heart and soul for protracted periods of time. And not only are they faced with the pain and the death when they are at work, but their usual support structures are not available. And that is due to the things like social distancing, gymnasiums being closed. It has created a great deal of difficulty, and we are seeing a lot of burnout, particularly within our junior staff, though it is apparent across the age spectrum. And it really comes down to the concept of compassion fatigue. We as emergency physicians know everything about hard work. We do it every day. But you get to a point where you feel that you've given every ounce that is within your heart and you have nothing more to give. And I think that's one of the biggest concerns I have at present with regards to the healthcare fraternity in South Africa, is that their tanks of compassion are running on empty. And with our vaccination drives sitting where they are, we are almost assured of a fourth wave. And it is going to occur at a time which is usually a time for families, and that is over the Christmas period in South Africa. And so once again, these healthcare workers will be isolated from their families for their own protection. They will be faced with horrible and terrible decisions with regards to allocation of resources. And at the same time, they are being told that what they are doing is against people's human rights. And that does result in a great deal of concern. And it leaves me awake at night, and I think that applies to a lot of the healthcare workers in this country. Where to from here is always a question. It felt that 2020 was the longest year that I've ever lived through, and it seemed to be never ending. But now that we look back, we realize it is gone, and we need to look forward to the future and what our new normal is going to be. And that is the question mark. We really don't know. We hope that the vaccines will produce a level of protection that will not only protect healthcare workers, but also protect their access into health, the patient's access into healthcare for other diseases. But we simply don't know. What we do hope is that it is a light at the end of the tunnel and not a train coming in the opposite direction. And with that, I would like to thank you for the opportunity once again to have participated in the EPAD conference and to hear such familiar voices. And finally, I would like to pay tribute to the Grand Master of this conference, Professor Bashakanda. And with that, it's my pleasure to hand back to Lewis and to Eric. Thank you very much.
Thank you, Roger, for this presentation. Probably there are questions regarding your comments. There is one question from Mehmet. Question is coming, Roger. The microphone is flying. And
Good morning. Can you hear me?
Good morning.
This is Dr.
I can
Behçet.
hear you clearly. Please go ahead.
Okay, Dr. Roger, welcome. Thank you very much for your nice presentation. This is Dr. Behçet. My question, okay, thank you very much. Especially is for you, but for all the audience. As health staff and provider, we believe that the unique treatment for this disaster is using the vaccination. This is the unique treatment. All other treatments are supportive. We believe that. And we strongly have recommendation for ourselves and our population to have vaccination. The question is that, do you think or do you believe that we did a mistake while we are talking about the benefit of the vaccination, why we could not be able to convince the population to have the vaccination? Because at all over the world there is a strong position about this vaccination. Thank you very much.
Listen, I am 100% in agreement with you. We've seen this with previous pandemics, and we look at things like smallpox and polio, and the way that those were controlled and eventually eradicated was through immunization and vaccination. I think whilst the scientific community has been very strong in favor of vaccination, its benefits, not only in limiting the spread of the disease, but in particular decreasing the incidence of severe disease, the requirements for hospitalization, and the requirements for intensive care, and by doing so, limits death. The realm of fake news and social media has done a lot of deleterious damage to that very strong message that is coming from the scientific community. And we've seen it certainly within South Africa, and I'm sure across the globe, where self-proclaimed experts, after reading an article on Wikipedia, will sprout nonsense about how the vaccine is going to cause the sprouting of a third ear. And everybody is then frightened that the vaccine is going to give them an extra ear in the middle of their forehead. I think the way to go through this is taking an approach when you're sitting on the back of a donkey of either using the stick or the carrot. So we can try and encourage using the benefits of the carrot, and I would have thought that the benefit of survival is a significant one, but it doesn't seem to have been shown. And so do we need to have more draconian mechanisms in order to ensure vaccination? And compulsory vaccination is not something that is new. We've seen compulsory vaccination for many other afflictions across the world. There's been mass debates with regards to whether healthcare workers should have compulsory vaccination, and there's not even clarity in that regard. What our country is trying to do, and it has been since the launch of an electronic health pass, is that they are using that as motivations. So they've reintroduced things like sports matches with some of the professional teams with limited numbers in the stadia, but you do not get access to that stadium unless you are fully vaccinated. And so those are the motivations that are currently being used in order to try and motivate individuals who perhaps would ordinarily be on the fence to actually proceed and get the vaccination. What is encouraging, though, is that if we look at the interest in vaccination, it is highest amongst our youngest population. We're finding it is in the middle age groups of the 30s to 50s that we have the greatest difficulty. The young people are flocking to vaccination centers, and I think it's because they realize that it's the only way that they can get back to a normal life. The final comment in that regard is that I did appreciate the comments of the French president with regards to vaccination and how various entities, the access would be limited if you were not vaccinated. And his comments about it's the time for everybody hiding because a few will not be vaccinated is over. It is time for those who are unvaccinated to hide. And perhaps that is the approach that we are needing to take. I am vaccinated. I was fortunate to be vaccinated in February of this year, so very early on in the vaccination programs in this country. It was after I had had COVID and was quite significantly ill from it. And I certainly don't want to go through it again.
Thank you.
Thank you, Roger.
I am afraid that we have to go on with the program. Thank you for your answer. Roger, can you hear me?
Yeah, Roger, we cannot hear you. Roger. Yeah, okay. Thank you. The connection is not stable for now. Thank you, Roger. We have to move forward to the next speaker. And I would like to introduce Dr. Kumar about the situation in Asia. Thank you. Thank you, Roger.
Thanks, Eric. Thanks, Lewis.
Thank you again.
Good morning, everybody. So, you saw Roger and Wang Zhong discussing about the COVID report in their countries. I'm been given a task about speaking about the full Asia continent. And when it comes to Asia alone, we all know that what is the population there and how much it contributes to the whole world. So you can see the Earth's largest population is in Asia, contributing to two major countries, that is China and India. China has 1.4 and India has 1.3 billions. So for full put together, it almost constitutes to about 40% of the population of the world. And then, as of June, 4.5 billion people constitute roughly to 60% of the world's population that's in Asia. So we all know where it started and where it was going through and where it came back. The only advantage which many countries had was by the time it came back to Asian countries, it was almost 3 to 4 months later on, wherein it gave a time for us to breathe in and look into the composition and how to manage these patients in the countries. So I've just taken all the statistics from the web page as on 8th of October 2021. Since we can't get any data from many of the countries, we have to look into the statistics from the web page alone. So if you see, out of the 48 Asian countries, if you take the top 10 countries, my country was the highest. That is 3.36 crores. But if you take per million or per crore population, my country is the lowest, because we have 1.3 billion population and we had 3.3 crores of total patients which was being reported as of October 9th. And that constitutes to less than 3% of the patients in the country. So next was the Russia, where they had about 75 millions, and then the Turkey, Iran, Indonesia, Philippines, Malaysia, Iraq, Japan, and Thailand. So, but what made important is when by the time it hit India, that was in March 21st, where the first case was been reported in one of the tiny states in the southernmost part of the country. So then, by then we had the protocols, the Indian Council of Medical Research, which is the highest body in our country, along with the Ministry of Health and major players, because in India, if you take the healthcare providers, it is 80% by the private sector and 20% by the government sector. So they did a major job. They involved all the stakeholders, brought out the protocols, and then they said that this is what is the protocol for the whole country. And then they went into the lockdown on March 21st, so which brought in the number of count to very, very minimal in the first wave, which started from March 21st, though we saw the spike only when the average test positivity rate, which we saw, once it touched to 3%, then it started spiking. The highest peak which we attained was in the month of May and June, which went up to 21%, and it stayed as a plateau for almost a month, and then it started reducing. And most of the Asian countries had only 2 peaks. They didn't have the 3rd peak as it was shown in South Africa or many other continents. Only in few countries in Asia, like Japan, had a 3rd or a 4th wave. But in my country, there was only 2 waves. One was in April, May, and then again it came down by August, September, and by October we were coming down to minimum numbers, and again it started peaking in the month of March. So we saw the next peak again in May, and it came down drastically in the month of June. So if you see the number of deaths again, India was contributing to the highest number of deaths. That was 4,46,000 deaths which occurred as of October month. So again, if you see in the number of population, that was coming down to less than 0.1% of the population. And if you see the total number of patients, that was 3 crores, and 4 lakhs was coming to about 1.3%. And that was because of the robust protocols which was being present. And if you see, as on October 7th, the number of active patients, that was again in Russia, that was the highest number, that was 6,50,000 patients, and Kazakhstan, that is 55,621. And if you see in my country, it is hardly about 20,000 patients as of today. And if you come to total cases per million population, you can see what I was telling is true, wherein India doesn't stand anywhere. That the per million population, you see the Georgia is the highest number of patients, that is 1,57,000, and Turkey has 86,000 per million population. And if you see the tests per million, we have been doing X number of tests, but again, the highest number of tests were done by UAE, that is 85 lakhs per million population. And if you come to Bhutan, it was about 14 lakh tests per million population. So Turkey stands in the 12th place, about 10 million tests. And again, if you see the deaths per million population, you can see that, again, India doesn't stand here in the first top 10, because when you look into top 10 positions per million population, again, it's not there. Again, Georgia is the highest, and Oman is in the number 10th position. And Turkey stands at 767 per million population. So the solution, as every one of us have said, it is vaccination, vaccination, and only vaccination. So what many countries did was, it started vaccinating the people in December or November itself. So by the time it came to the Middle East, low and middle income countries, it was very late. That was in January. So, but in January, when we started on January 16th, till today, as of today's morning, in India, 95.8 crore people, that is almost looking into 20% of the population of the world, has been vaccinated in India alone. This particular robust vaccination is because we have a good networking system, especially there is something called as the ASHA workers or the Anganwadi workers. So they were the one who took the torchbearer, and when it came to polio or any other vaccination strategies, they were the one who helped out rather than the nurses or the doctors, which the nurses and the doctors were playing a major role in treating the patients in the hospitals rather than giving the vaccinations. So these people went to the land and rural area and started vaccinating. That was very important. That is why you can say that 73.7% of the population in India have been vaccinated. We have 3 vaccines basically. The one is AstraZeneca. Second one was the one which was indigenously developed in our own country, that was Covaxin, and the third one which was been imported from Russia, that's a Sputnik. All 3 are double dose vaccines, and according to our scientists, they had a leverage of 28 days initially between all the vaccines, and now in the AstraZeneca they made it as 84 days. And believe it or not, the healthcare workers in India, you can see that there are more than 4.5 lakh doctors in India. The number of persons who were succumbed to the illness was 952 doctors by August of this year. That means that because of the vaccination process and the vaccines which all the healthcare providers took, reduced the number of deaths. And again, we saw that those who were vaccinated among all the healthcare providers, that is, let them be the doctors, nurses, or the paramedics, we saw that the patients who came with the vaccinated people, the requirement for ICU and ventilation was very, very low, including the most emergency physicians who were working in the emergency departments. We all know that. And you can see the population which was been vaccinated. Again, Singapore stands highest with 80.8% and Sri Lanka with 54.6%. The only thing is vaccination, we have to keep on telling to everybody, and Turkey stands at 54.1%. And if you see the Asian countries' response, the top 3 countries are the Bhutan, Oman, and Taiwan, and which need to take action of Philippines and Malaysia, where the vaccination and the response system should be robust enough. So what made difference in our country was testing at the initial stage itself. Anybody coming from outside the country were subjected to test, and the quarantine process was a robust one and indigenously prepared, because at that particular moment initially we didn't have the cabins to test. So indigenously the army people in the Indian Army started preparing a lot of things like this and gave it to our country, and that made very safe and made very helpful for making the testing happen. And increasing the testing decreased the number of patients visiting the hospital. And the PPEs, initially we couldn't find any PPEs because most of the import was banned. And then they developed indigenously again, and they looked into and brought in the PPEs which is required and made sure the frontline workers have been given every time. And the number of hours, number of working days, everything was staggered. We had our own hospital protocols. Initially, we said that 7 days you work, 14 days you take off. And then we reduced it from 7 to 7 days. And once they were vaccinated, we saw that the number of staggering hours was reduced. And this motivated all the healthcare workers to participate, to treat the patients, and ensure that they get the highest level of treatment for the patients who come to the emergency department. Because we all know emergency is the front door, and you triage the patient, you give the treatment first, you are going to save the life, and that is what is very, very important. Social distancing, there is no other thing, we have to follow it. Follow the standardized protocols, which is important for your hospital. Develop it. Some may say remdesivir is important, some may say tocilizumab is important, but you can decide what is important, at which time, when the patient has to be started on oxygen, when the patient has to be put him on high flow oxygen, when the patient has to be put on NIV, when the patient has to be intubated. So the emergency physician is the #1 person who can stand and say that this is what I'm going to follow the protocol and do it at the best, because only later on you're going to shift the patient. And believe it or not, in my own hospital, our hospital was the designated hospital for COVID-19, and every day starting from March till date, we were receiving not less than 300 to 400 patients a day, and most of them were on panic initially. We used to see 400, 500 patients getting tested, about 1,500 patients coming in and wanted to get a test done in the hospital. That was a panicky situation which we saw in. And the whole burden came on emergency physicians and the emergency care providers. So, but we never lost our hope. We saw and we ensured that there was not even one casualty in my hospital from the healthcare providers' perspective. So we took care of them. That is what India did differently, and that is what which many countries took the leave and they looked into how they can reduce. You can see all over the world there were 150,000 healthcare providers who died, but when you see country-wise, it is number which is less. So this is how you have to indigenously process them, construct them, review them whenever time and again is required, and then you have given the best care out of you to the patients who visit. Emergency, I always say that it is not a single man's job. It is always a teamwork. You have your core team with your group and make your protocols, vaccinate them, say to them that vaccination is the most important thing, and ensure that each one is teaching another person to save more lives. That is what is our tagline every time when we go there. Thank you all.
Thank you, Dr. Kumar, for this presentation and impressive numbers. Do we have any question in the audience about this situation in Asia? I've got one. What's the situation today? I mean, for different countries, what's the most threat you think it is now in Asia?
I saw the statistics yesterday night. It was not alarming in Asian countries. Like I said, my country had about 19,400 patients as of yesterday night for a population of 1.3 billion.
Yeah, thank you again, Sirinat.
Thank you very much.
Unfortunately, we have to move to the next speaker. Now from Mexico, Jesus Daniel Lopez is coming to report us about the situation in his country. Please, Jesus.
Thank you very much for the introduction, Dr. Eric, Dr. Luis. I have 5 minutes, I think. And I will talk about the Latin American experience with COVID-19. And I want to call my talk, why didn't we learn? But not just in Mexico, I think all the countries. Why didn't we learn about COVID-19? When did it all start in Mexico? We had the first case in Mexico in February 28. Somebody 35 years old who traveled to Italy for work. And when he got to Mexico, he was the first case in our country. But in Mexico, we aren't prepared, and Latin American were not prepared for this situation. Why? Because if you remember, when the pandemic started or began, everybody told it's like a flu. It's not dangerous. The influenza is more dangerous. Don't worry. Because we saw the numbers of Chinese, and the mortality was very low. But what happened with Mexico? Sorry? Okay, sorry. What happened with Mexico? Our mortality now is 11–12%, because, as you know, we have a big problem with the obesity, and I'm sure your patients, when the more critical patients are very fat patients, and we have that problem. Our mortality is the biggest in the world, 11–12%. Some cities, 15% of mortality. It was the first mistake. Trust. The other mistake, I don't know if you remember, we thought the COVID-19 is just in the north of the world, not the south. Why? Because we imagine the BCG vaccine protect the population. And South America and Africa didn't have COVID-19 when the pandemic began. And we thought this kind of vaccine protect our population. It was another mistake. And the other, I don't know if you know the Sentinel program. The Sentinel program is when you get the information about how many cases do you have in your country, and then it's just the 10% of the real cases in your country. If we have one day in Mexico 1,000 of cases, really we had 10,000. But it was similar to the influenza. And as you know, it's not similar. The spread in COVID-19 was more. And then we thought we have maybe 10,000 cases when really we had 20,000, 30,000 cases. It was another mistake.